Hello, everyone. Please note that this session is being recorded. Welcome to this Global Health Conversation series. We greet you from the University of South Florida in Tampa. My name is Miguel Reina Ortiz, and I am an assistant professor of global communicable diseases and global health practice in the College of Public Health at the University of South Florida. I want to welcome each of you and our many partners from around the world to this conversation. The COVID-19 pandemic continues to create havoc around the world, and its destructive path has left no community untouched, with some populations bearing a disproportionate burden of the negative effects, and especially refugees around the world. Dr. Ahson's topic is the merging of two crises, the impact of COVID-19 on global refugee crisis. And this is a poignant topic of a population that is too often excluded. We will look forward to hearing from Dr. Ahson's topic today. And before I introduce Dr. Ahson, I just wanted to let you know that at the end of her presentation, we will have plenty of time for questions. So please type your questions in the chat box during the presentation, and she will try to answer as many as she can at the end. Now, let me give you a brief biography of Dr. Ahson's. Dr. Minal Ahson is an assistant professor of medicine and pediatrics at the University of South Florida. She's a hospitalist with a specialization both in internal medicine and pediatrics on the COVID-19 response team at the Global Emerging Disease Institute at Tampa General Hospital. She has extensive experience working on humanitarian medical response around the world, with a particular focus on refugee communities in Jordan and Bangladesh. She has also directed and taught courses on refugee health and humanitarian medicine at USF Morsani College of Medicine, at Georgetown School of Medicine, and at UC Berkeley. With this, I would like to let Dr. Ahson continue with her presentation. Thank you.
Hi, good morning, everyone, or good evening to our participants from overseas. Good afternoon. Thank you so much for joining. I'm really honored and privileged to be able to give this talk today. COVID-19 is now confirmed in crisis-affected countries like Afghanistan, Iraq, and Burkina Faso, where populations were already in need of humanitarian assistance before the outbreak. 80% of people in need of humanitarian aid live in countries with high levels of displacement, as well as overstretched and weak infrastructure. Many of the prevention tactics and treatments available in developed countries may not be readily available in these countries. So how and why is this important? So, just a little bit of personal background around me. Thank you so much for the introduction. I actually am a native Floridian. I studied from the University of Miami. I studied for a year at the London School of Hygiene and Tropical Medicine, where I was fortunate to meet colleagues from all over the world that I'm still in touch with and hear about the wonderful work that they do. I did my internship and residency from New Jersey, and then I was here at the University of South Florida, where I currently, as mentioned, work as a Med-Peds Hospitalist, and most recently, really on the front lines of the COVID-19 crisis here in Tampa Bay. I am also a chairperson of Volunteers and Networks Committee of Med Global, an NGO that's dedicated to decreasing healthcare disparities worldwide. I have volunteered in 7 different countries, including 2 refugee camps around the world. So some of this information is coming from personal experience, and some is a lot of it's coming from discussion with colleagues and research from projects from around the world. So what will we discuss today? Firstly, we'll describe the global refugee crisis. We'll next define the unique challenges that make refugees vulnerable to COVID-19. Describe COVID-19 in refugee communities, detail potential areas of concern in refugee camps, discuss secondary effects of the pandemic, and then propose strategies to mitigate the spread. So we have right now, at this point in time, the worst refugee crisis at any point of time in history. There are currently 79.5 million forcibly displaced people worldwide by the end of 2019. And the majority of these statistics actually come from UNHCR, the UN High Commission on Refugees, or the International Committee on Refugees. So, and they're released at the end of the year, and there's an update in the middle of the year. So this is the mid-year they're released in the middle of the year. There's an update at the end of the year. So the mid-year update for the official numbers were 79.5 million. The number from December that are looking like this number has increased because of the economic strain of the pandemic. So of the 79.5 million forcibly displaced people worldwide, 26 million people are refugees. This means seeking shelter outside of one's country. 45.7 million are internally displaced, so taken away from their own homes, maybe seeking shelter in different part of the country. 4.2 million are asylum seekers, and 3.6 million Venezuelans are displaced abroad. To put that into perspective, that's 1% of the world's population that's displaced. 80% of the world's displaced people are in countries or territories affected by acute food insecurity and malnutrition. And 73% of these people are hosted in neighboring countries. What are the top 5 hosting countries? So Turkey, Colombia, Pakistan, Uganda, and Germany. I'd like to point out that all of those 5 countries, the most developed country is Germany, and they have the least amount of refugees, 1.1 million. And many other countries don't even make the top 5, obviously, or do not have are not hosting nearly as many refugees. 68% of these refugees come from just this 5 countries. Number 1 is Syria. As we know, the Syrian civil war has been going on for almost 10 years now. Secondly is Venezuela. Third, Afghanistan. Fourth, South Sudan. And lastly, Myanmar. So as of October 2020, the UNHCR estimated that about 21,000 of the world's 30 million refugees have tested positive for the virus across 97 countries. So what factors make refugees more vulnerable in general? Firstly, let's discuss housing. So when we discuss housing in refugee communities, we think of 2 different kinds. One is in refugee camps, and the other is in urban areas. Refugee camps can be both formal and informal. So today, about 60% of forcibly displaced people live in cities rather than camps. Cash relief has proven to be an effective way to reach them faster. It's also a more cost-effective solution than delivering food items, clothing, and in-kind donations in crisis settings. Choice empowers refugees to take control of their lives and decide for themselves what they need most. It also helps the local economy by bolstering markets and the vendors who operate within them. So in Jordan, for example, 80% of refugee families live outside camps, and many families rent accommodation at their own cost. In 2018, UNHCR supported about 32,000 families with a monthly cash grant of $183 on average per household. As most of these families live outside the camps, often in unfinished or abandoned buildings or substandard housing, cash assistance provides them a lifeline that allows them to pay for rent and avoid homelessness. In Lebanon, where refugees represent about 25% of the world's population, or of the country's population, UNHCR has upgraded and repaired and completed about 7,000 partially constructed buildings, which are the only option for shelter. So in exchange for UNHCR's investment, landlords are obliged to provide refugees with rent-free agreement or a rent reduction, usually for a whole year. And similar programs have happened in other different countries, including Greece and Iraq. So this is a series of illustrations by a really talented artist named Mona Chalabi. She does a lot of social change illustrations. You can find her on Instagram. She also has a website. But this one in particular, I thought really illustrated nicely how COVID-19 spreads faster, especially in refugee communities. So we all heard about the Diamond Princess early on in the pandemic. So on the Diamond Princess cruise ship, I think that was one of the first examples of how COVID-19 spreads in densely populated areas. So there were 24 people per 1,000 meters squared on board. The virus spread 4 times faster on the ship than it did in Wuhan, China, at the peak of the outbreak there. In Cox's Bazar, Bangladesh, which is the refugee camp that houses almost 1 million Rohingya refugees, there are 40 people per 1,000 meters squared. And at actually some of the most crowded parts, it can go up to 70 meters. In Moria Camp, Greece, there are 204 meters per 1,000 meters squared. And this is Moria Camp. This is Lesbos, Greece. It's one of the Greek Isles, and it's one of the most densely populated camps in the world. So this camp initially was designed for 3,000 people, and at one point it held about 20,000 people. So this camp, as you can see, is surrounded by olive groves. So those people that do not find shelter within the camp basically have set up informal camps outside of Moria Camp. A fire destroyed Moria Camp, unfortunately, in September of 2020, leaving 13,000 people without shelter. So Kara Tepe is the new tent city that was hastily built after the fire, since the blaze leveled everything there. And around 9,000 migrants and refugees have been resettled on this island, but thousands more remain homeless. As one of the smallest countries in Africa, Rwanda is hosting around 77,000 refugees from the DRC and 71,000 refugees from Burundi, among others, in camps and urban settings as a result of election-related tensions in the neighboring Burundi. Rwanda has opened its borders to Burundian refugees who have fled the country since April of 2015. Mahama Refugee Camp, which is UNHCR's 6th camp in Rwanda, has become the country's largest camp, hosting around 60,000 refugees. During the emergency period, the camp had more than 4,000 family tents. This is the tents here, and more than 170 temporary communal hangars. So they received, after receiving funding for shelter, they actually were able to construct and transform the temporary shelters into semi-permanent shelters. So these are actually right here, these semi-permanent shelters. They're a roof of dual shelter made from corrugated iron sheets with aluminum coatings on both sides covering the timber structure from the top of the walls. Each shelter has 4 rooms and allows comfortably 8 people to live in that area. They're made of mud bricks produced from local soil mixed with straw as reinforcement and dried in the sun. And each shelter has 4 windows for aeration and sunlight. The doors are made from timber and works with a locking system on both sides. And the family living in the shelter can use a padlock to lock the door from the outside when they're not home. And it can last for upwards of 10 years with adequate upkeep. This is Zaatari Refugee Camp in Jordan. It's home to almost 80,000 refugees, and more than half of these are children. So since 2012, the camp has been divided into 12 districts and has grown from a collection of tents, right here, as you can see in the upper left corner, at its peak, to a semi-permanent city, as you can see down here. These are the bottom left corner shows the rows and how it's divided and been organized, and the bottom right shows the semi-permanent housing. At its peak, it housed around 150,000 Syrian refugees, becoming the 4th largest city in Jordan. So 19,000 children are enrolled in about 32 schools with 58 community centers offering activities. 30% of the refugees in this area are female-headed households, and about 4,000 engage in incentive-based volunteering inside the camp. Weekly, there are about 9,000 consultations in the clinics that are provided and upkept by the UNHCR and some of their local non-governmental organizations, including the Syrian American Medical Society, with whom I volunteered in Zaatari camp. and about 13,000 refugees have active work permits. So this is actually new, and I'll talk about it with employment, but in most countries, refugees do not have permission to work in surrounding areas because that causes a lot of the countries to have competition between the host community. Refugees may be taking jobs at lower wages, and it provides issues. So in Jordan, they've actually set up a work permit program that does allow refugees to work outside of the camps, and I'll talk about it a little bit later. So the Rohingya refugee camp in Bangladesh is home to almost 1 million refugees. And these 3 pictures are my personal pictures. I visited this camp first in October of 2017, right after the refugee crisis began in August of 2017, after the genocide in Myanmar escalated, and almost 800,000 refugees immigrated at that point, crossing either a river or mountain to reach Bangladesh. There were already 100,000 to 200,000 refugees living there in old camps that were established in the 80s when there was violence at that time. So these are my personal pictures. As you can see, these shelters are semi-permanent. They have kind of a tin roof, and they're held together with, these are bamboo poles that have tarps that hold them together. And they're constructed by the assistance of the UNHCR and other non-governmental organizations that focus on housing. As you can see, it's very muddy in this area. This particular side of the camp, as you can see, people are climbing down into it, so it can get very slippery during the rain, and this type of temporary housing obviously poses health risks. And 8 to 10 people would live in one of these shelters. And as I'd mentioned before, the community, it averages about 40,000 people per square kilometer, can increase up to 70,000 people in the most cramped areas. And by comparison, Wuhan, China was about 6,000 people per square kilometer. And this is an aerial view, and I just like to show this to give you an idea of the scale of the camp and how many 1 million people crowded into such an area. And as you can see, the shelters are so crammed together and very close. So what are some of the health risks due to inadequate housing? So one study done in Sri Lanka demonstrated that poor housing conditions in refugee camps found that living in a transitional camp, so semi-permanent housing, compared to a permanent house, was a significant risk factor for coughs, stomach ailments, headaches, and generally feeling unwell. Mentioned overcrowding. Many of these households, 8 to 10 people, live in very close proximity. So you can imagine if one person gets sick, how rapidly that would spread, especially respiratory illnesses. Many of these shelters have cooking fires inside the homes. So you can think about the smoke and how that can exacerbate respiratory conditions such as asthma, COPD, which can make you more prone to picking up a respiratory illness. Malaria also poses a huge threat for adults and children alike in refugee camps, especially when they live in very close quarters without windows or screens, window screens or solid doors. Climate factors such as natural disasters in these areas. So the Rohingya camp especially is in a monsoon-prone area. So I remember specifically in a different presentation, I have this picture, but monsoons wipe out entire whatever has been constructed, because these are not permanent housings. These are not permanent abodes. So one organization had constructed this beautiful playground for children, and unfortunately by the next season when I went, it was completely washed away. And you can think about how not just climate, but snow, maybe in some places, humidity, how this can make areas and housing prone to maybe mold or other conditions that can cause dampness that may exacerbate health issues. Rodents have also been found in many of these houses, which, for example, in West Africa, carry Lassa fever. This can also affect mental health, because if you know that your house may be blown away in a monsoon, it increases anxiety and stress and how one will protect their families. We'll talk about access to water in an upcoming slide, but that's very important. Are these common latrines? Does one have to leave the camp to go somewhere else to find water? We'll talk about hygiene and sanitation as well. And then also fires. You can imagine if a fire breaks out in one home, how that will spread like matchsticks to other homes and cause homelessness and respiratory issues. So though the importance of having adequate latrines is well documented, still only 30% of refugee camps do not have adequate waste disposal services or latrines. A study conducted in refugee camps in Bangladesh found that camps that provided sanitation facilities had cholera rates of 1.6 cases per 1,000 people, while camps that had no such facilities had cholera rates that were almost 3 times greater, so 4 to 4.3 cases per 1,000 people. So a study in Kenya found similar outcomes, that sharing a latrine with 3 or more households was found to be a significant risk factor for cholera due to an increase in fecal oral transmission of the disease. So sometimes these latrines can be communal, like in the Rohingya camps. Household latrines serve clusters of 5 families who are responsible for keeping them clean. And there are also community facilities that serve whoever is visiting that particular area. And then there's also in certain camps in-home latrines, and there's programs that are cash for latrines. So the family can invest a small amount of money to be able to have the latrine in their home. Some of the benefits of having latrines in general, and then specifically in-home latrines, obviously it provides dignity to the family, that a dignity to the refugee, that they don't have to go into the bush or into, somewhere else to obviously do what is natural to every human. It improves health, as I'd mentioned, cholera rates. And lastly, in terms of safety, also for women, especially, as I'd mentioned in Jordan, a lot of households are women-headed because many of the men were killed in the war. So, for women that are living by themselves, having either in-home latrines or communal latrines within maybe households of women is safer for women than going out into a bush where there may be a lot of unknown people. So the UNHCR estimates that more than half of the refugee camps in the world are unable to provide the recommended daily water minimum of 20 liters of water per person per day. Ensuring that refugees receive an adequate quantity of water is an important public health issue because of the lack of clean water is correlated with the presence of diseases such as diarrhea and cholera. And as we can talk about COVID-19, obviously we talk about hand washing. Hand sanitizer is likely not available in many of these settings. So if we do not have adequate water, adequate hand washing is not possible. So a 2005 study carried out in a refugee camp in Kenya found that there were 11 cases among households who had access to 110 of cholera, that had access to 110 liters of water a day. Meanwhile, there were 32 cases of cholera among households who had access of 44 liters per water per day. The other issue is how far are these water points? So studies have documented that the further a water point is, the less likely somebody's going to go and get water for the home. So the less water comes into the home. So making the water points accessible is very important. How much time does it take to access these water points? Does it take half of the day? At that point, maybe, the trade-off is not getting as much water as is needed by the household. And then obviously hygiene. Where is this water coming from? Is it clean? Is it potable? Is it something that can be used safely to wash hands, or is it contaminated and will cause more disease? And lastly, environmental exploitation. So we talked about where the water comes from. Is this digging into the environment? Is that going to cause more problems? Is there potential for contamination that will spread throughout this community? There is a very moving quote that I read when I was putting together this portion of the presentation. It was from a volunteer, and he wrote, he said, and I quote, "I spent years in a refugee camp in Ethiopia. There I watched 2 young boys, perhaps 12 years old, fighting so viciously over rations that one kicked the other to death. He had not intended to kill his foe, of course, but we were young and very weak. This quote was from a refugee, sorry, not from a volunteer. This quote was from a refugee, highlights the realities of living in a refugee camp where there is not enough food in the camps. Chronic malnutrition makes refugees fragile and more susceptible to a variety of diseases and illnesses. Most refugee camps do not have sufficient food to provide their populations, and refugees are frequently dependent entirely on humanitarian aid. So the UNHCR recommends that each refugee receive more than 2,100 calories a day, but often camps fail to meet this standard. For example, in 2005 and 2006, the daily amount of distributed in a Tanzanian refugee camp were 1,700 and 1,400 kilocalories per person, respectively. So there are multiple ways that food is distributed, like in this picture. Household rations are often distributed. When I went to the refugee camp in Bangladesh, because it was such an acute event, initially the first time I went, it actually was prepared food because there was no way to distribute firewood, and so families did not have utensils to cook themselves, so the food was prepared. On subsequent trips, it was more of a ration system like this. Some programs in certain countries are more of a voucher system, so similar to the cash for housing, vouchers are provided to family members so that they can go and purchase food themselves. There's often bartering, so if a lot of times people may barter food for other goods, things like that. Oftentimes the food may not have a variety, may not provide all the vitamins and nutrients required to maintain essential health. Home Gardens is also a program that was started in a refugee camp in Zambia, which is more of a permanent settlement, and they're encouraged to grow their own food in small gardens, which helps cut down on malnutrition in those areas. And then there are also a lot of refugee camps that provide, that have malnutrition programs for children that are falling off the growth curve and may need more supplementation that can be provided by just the rations. We talked about, I mentioned briefly work income programs, but refugees are often restricted, have restricted movement. Many camps do not allow refugees to leave. If you are claiming refugee status through the United Nations, one of the stipulations is that you stay in your camp. Certain countries like Jordan has worked out a program with the UNHCR, given refugees permission to work. So certain jobs in certain fields are accessible to refugees, and it's kind of like a work-study program. In certain areas, refugees are also provided with a stipend, like I'd mentioned before, for maybe volunteering in the camp. At Zaatari camp, we actually had quite a few nurses, teachers, doctors even, that were living in the camp that assisted and were provided a per diem by the organization. So I talked about specifically about housing and what puts refugees at higher risk. We talked about overcrowding, so difficulty to socially distance, higher risk of contracting illnesses, poor sanitation. So we talked about, limited access to clean water, hand sanitizer, and toilets, malnourishment, which obviously if you're malnourished, then more likely to be impacted by certain illnesses, and then increased physical and mental stress. So physical stress, we saw some of the conditions that these camps are in, very difficult. Zaatari, I didn't mention, is obviously, Jordan is desert. It can be very harsh climates, extreme heat to extreme cold, and very dusty and sandy. So, this causes physical stress on the body, but then also mental stress. Many of these housing are not permanent, they're semi-permanent. So, the dealing with the possibility of your home blowing away or, being rained away. Specifically with COVID-19, it's been identified in dozens of refugee camps around the world. It impacts mental and physical health. And not only does the virus impact refugee communities, but there are secondary impacts of the pandemic. So this is actually just from this morning from Johns Hopkins Coronavirus Resource Center. We are at 107 trillion million cases worldwide, and 2 million deaths. So this is crazy, as we can see that it's spreading everywhere, and basically 192 countries around the world have been impacted by this pandemic. Where has it spread? So in terms of our refugee communities, in September of 2020, the first 2 coronavirus cases were detected at Azraq camp for Syrian refugees in Jordan, which is home to more than 40,000 people. This is an issue of concern because Azraq camp in Jordan houses around 80,000 people, and there are more than 650,000 refugees, Syrian refugees, living outside of the camps. So, you know, if some of a few people are impacted and they travel for work, or you know, one of these job stipend programs, there's a possibility of spread. So as of November 11th, 2020, there were 348 confirmed cases and 10 reported deaths in the Rohingya refugee camps. In September of 2020, the Greek islands of Lesbos, more than 240 people tested positive for coronavirus after the fire that destroyed Moria camp that I discussed about. COVID-19 has been identified in dozens of refugee camps worldwide, including Bangladesh, Syria, and Organization for Economic Cooperation in developing countries like Germany in refugee communities. So in comparison to other countries like the United States, why are we seeing such few cases in refugee communities? So first of all, likely a lack of testing. You know, testing is not available in many developing countries, but especially in areas of humanitarian crisis is probably one reason. Secondly, there were strict lockdowns. So when this all started, because of their isolated nature, it was possible to lock down who was going in and out. A lot of aid was cut off at that time. A lot of aid that was provided to these areas had to be stopped to prevent coronavirus from entering these areas. So as all lockdowns were lifted and the economies and borders reopened over the summer, it was inevitable that the virus would find its way into several camps. And that's why we were seeing the cases coming out later, as I previously mentioned. About half the refugees worldwide are under the age of 18, according to the UNHCR. And because of this young age, maybe perhaps they're less susceptible to having severe infection of the virus, and they're able to recover quicker. And because maybe they have less symptoms, they're less likely to get tested. So our rates are lower. There's also this talk of there being this hidden outbreak because of this younger demographic, and perhaps, you know, we're not testing, maybe the numbers are higher. But one thing that goes against that theory is that we're not seeing other indicators increase. We're not seeing rising numbers of deaths or, you know, respiratory illnesses in these populations. But we are seeing now that the numbers have started to rise. So this was a quote from a director of Human Rights Watch, Refugee and Migrant Rights Division. If the disease gets introduced into one of the refugee camps, it would be like a tinderbox. The case rates we have so far seen are just a lucky break. So let's talk about the impact on physical health. Obviously, we have a lack of resources to diagnose and treat many of these communities. Testing equipment, availability of medications that treat, remdesivir is an IV antiviral that's given in many developing countries. It's something that we use often on our COVID ward. Many of these areas may not have access to this medication. We talked about malnutrition, but if a patient is malnourished, they're more likely, or they will have more difficulty in overcoming any kind of illness, but especially COVID-19. And then in terms of resettled refugees, their access to healthcare. So do resettled refugees know how to access healthcare, where they can get help, where they can get tested, because of language barrier, because of financial issues? And there was an interesting survey done by the WHO that I will share next. In terms of lack of resources, PPE, there was initially, as we know, PPE shortage in many developed countries around the world. You know, we lacked proper masks were being reused, adequate testing capacity. We talked about the inability of that, but also limited access to healthcare facilities or damage to existing facilities from war, from climate issues or lack of upkeep because of the lockdown and inability of aid to reach where it's needed. Ventilators are very rare in many developing countries. Healthcare professionals may not be available in a lot of these places. A lot of, for example, in the Rohingya refugee camp, 3 of the hospitals were field hospitals in the camp were run by international NGOs, MSF, so Doctors Without Borders or Médecins Sans Frontières, the International Red Crescent, and there was a Malaysian field hospital. All of these volunteers came from overseas. So many countries, including Bangladesh, had limited the amount of volunteers that could come in. So there were limited staff that could provide adequate care. But even if the healthcare professionals were there, they may not have had the resources to treat. And then in terms of sanitized facilities, so if there is an outbreak, is there proper equipment to sanitize the facilities prior to other patients coming in? So food insecurity has increased during this time. For example, in South Sudan, a country where almost 65% of the population already relies on humanitarian assistance, economic instability, they may face famine as a result of restricted movement, economic instability, and reduction in agricultural labor. And this will add on to the pre-existing levels of malnutrition and chronic food insecurity. So in face of government mandated shutdowns, millions of people have lost their income, agricultural harvests and sales have been disrupted, food prices have increased, and aid programs focused on nutrition have been disrupted. So acute malnutrition among children is highly treatable, but the current health facility-based model for treating it may not be safe or practical within the COVID-19 context. So this slide is just difference between wasting and stunting, and for the purpose of time, I'm going to skip that. And these are just a few examples. This was a really interesting survey done by the WHO. It's called a Part Together survey. It's a preliminary overview of refugees and migrants' self-reported impact of COVID-19. It was published in December of last year. And this actually was a survey done of resettled refugees as well as some refugees in refugee camps. And it pooled their responses on a lot of different topics. And I'm going to share some of the pertinent responses. This was one reason for refugees to not seek medical care for COVID-19 symptoms, and this was about 1,200 respondents. So the majority, as you can see, 35% was because of lack of financial means. 22% was fear of deportation, 12% lack of availability of health care, 10% no entitlement to health care. And then there were other ones like language barrier, lack of transportation, did not trust the doctors, a lot of other reasons. But I thought this was very interesting and gave an insight into why healthcare was not accessed in this community. Obviously, COVID-19 has impacted mental health all around the world. It's increased stress in many of these communities because not only the stress of, the fear of the virus itself, but the lack of income because of the decreased ability to move, decreased agriculture output, as I talked about, decreased ability to sell. Domestic violence has increased all over the world, and including in refugee camps. This WHO survey, so this particular portion of the survey had about 30,000 refugees and migrants from different regions, expressed increased depression, fear, anxiety, and loneliness. And they also expressed an increased use of drugs and alcohol to cope with the virus and the pandemic. And this is actually in survey or graph form. You can see where the respondents were from. So if they lived in a house apartment, asylum center, refugee camp, or on the streets, and basically what emotions and mental health impacts COVID-19 caused. So we talked about increased depression, worry, anxiety, loneliness, and many other negative impacts of the virus. So that's all direct impact of COVID-19. What about secondary effects of the pandemic? The pandemic has decreased funding for child education. There have been mandatory school closures in some countries, and it's difficult in a lot of these areas to have remote learning. There may not be steady internet access, there may not be computers available, there may not be tablets available. I know in certain refugee camps, UNICEF has tried to encourage remote learning while promoting entry back into schools. But this has been a very difficult process. And actually, I found this really disheartening statistic. In one of the boot camps in Bangladesh, 29% of adolescents were enrolled in non-formal school before COVID-19, and after this closure of the learning centers, when they started to reopen, less than 1% enrolled in informal school, using the internet or media to continue learning. So not only has this impacted childhood education, but there's been declining routine vaccination rates because of a lack of access. So many clinics had to close down because of lack of volunteers, but also lack of supply chain. But these supplies cannot get to where they need to be. So already in 2019, 135 million people were facing a food crisis or emergency. And this is a statistic from the World Food Program in 55 countries and territories, while an additional 183 million were classified in stress conditions across 47 countries with risk of further deterioration. And this was largely as a result of conflict and insecurity, weather extremes, economic shocks, or a combination of all of that. So according to a 2020 global report on food crises, the pandemic has exacerbated these pre-existing and ongoing drivers, mainly by causing economic activities to decline, which in turn led to economic loss and reduced household purchasing power and a multitude of food system shocks worldwide. So this caused about 270 million people, they're still working on the statistics for last year, but may have fallen into acute food insecurity. And if people do not fall into that category, there may be more increased numbers about food consumption score based in other regions. There's also been declining humanitarian aid. The global economic recession has led to major cuts in humanitarian funding for refugee camps, which has led to food shortages and limited employment opportunities for displaced people. So the Norwegian Refugee Council estimates that more than 3/4 of displaced and conflict-affected people have lost income since the start of the pandemic. And the spread of COVID-19 is already hindering the aid community's ability to address the needs of refugees by limiting where people can travel and where, how supplies can reach. But it's also a lot of funding has actually been focused domestically. So since people are focusing their aid domestically into their own country, going to first line workers and things like that, it's creating more food shortages, limited employment opportunities, and because of suspended travel, aid cannot reach and supplies cannot reach where it needs to. We discussed the increased financial hardship, but already refugees have had a difficult time in finding employment opportunities. And it's been even exacerbated by the pandemic, as I'd mentioned, because of all of those reasons. Many refugees, obviously, in developed countries, many occupations have the ability to work from home. In many of these communities, that's not a possibility. And governments, because of the stress at the government level, are unable to provide sufficient relief packages to these communities. So this is again from the Apart Together survey, and this is respondents identified being impacted by COVID-19 in various aspects of their daily living conditions. And you can see that worse, same, or better. Very few people respond with better here in terms of housing, in terms of safety, in terms of food and clothes. It's either mostly worse, mostly same, and a lot of worse. So this is actually an interesting statistic from the Center for Global Development, and it actually shows GDP growth that was projected in 2019 and what actually happened because of the COVID-19 pandemic. And I just want to show, obviously, all of the difference was negative. People did worse than projected because of the pandemic. And I wanted to point out that the top 3 countries that did the worst are all 3 of the highest refugee hosting countries: Turkey, Colombia, and Pakistan. So there's also been impact of COVID-19 by sector, and the reason why I point this out is because many of the sectors that were highly impacted are areas that refugees may have found employment. So accommodation and food services, manufacturing, wholesale and trade, transportation, construction, things like that. The low impact have been places like education, human health, public administration, and utilities, which may not be jobs that are accessible to refugee communities. Border closures can be life-threatening. 168 countries fully or partially closed borders, and 90 of these made no exceptions for asylum seekers. So many people who are seeking asylum that may have had threats to their lives were not able to pursue asylum during this time period. Refugee resettlement is at a 2-decade low. Already trends were declining in many developing countries, but from January to September of 2020, only 15,000 refugees were resettled worldwide. Several countries have now relaxed immigration rules for refugees and migrants who are medically trained to help combat coronavirus, but then this also leads to a shortage of essential workers in areas that may need them most. So what about the new variants? So new COVID-19 strains are spreading in conflict-affected areas like Lebanon, Jordan, Mexico, Nigeria, Kenya, Tanzania, Pakistan, and Greece, while new variants are feared to be spreading in Zimbabwe and the DRC. It's a double-edged sword. Controlling the spread of the virus means losing other services and protections. So, it's causing the balance, but as we see, the pandemic itself may not impact these communities directly. The secondary impacts may be greater. Because vulnerable populations are made more vulnerable. It can worsen ethnic divides in conflict zones, for example, in Syria and ISIS, Lebanon with Hezbollah. Many minority groups may be scapegoated, maybe rumors about how coronavirus is spread within certain groups, and this provides extremist groups opportunity to highlight the government's inability to contain the pandemic. And then there's also competition for resources that are already scarce. So what are some strategies to mitigate the spread of COVID-19 and refugee camps? So firstly is empowering local communities by education and creating their own supply chains. That sounds lofty and difficult, but this is obviously a slide of possibilities. Secondly, we can advocate for equal access to local health care in terms of testing, treatment, and vaccines when they become available in these communities. And lastly, funding for specifically targeting to populations in humanitarian crisis regions for PPE, hygiene and testing kits, and medications. There are many ways we can try to protect refugees from COVID-19 by shielding vulnerable groups. So there was talk about when this was happening, should certain populations be moved to a separate area. That's always a possibility, moving elderly or those that are immunocompromised, kind of isolating them and putting them in quarantine until a vaccine becomes available, communicating the risks and public health education, smaller distribution points leading to less gathering, a little bit more trying to enforce social distancing as much as possible, which is very difficult in many of these crowded areas, closing schools, which has happened, task shifting of healthcare professions. So, limiting who's coming in and out and maybe having one person do more than one task so that there's less exposure of new people, and then possible deployment of outbreak response teams if the crisis does worsen in many of these areas. So there from COVAX, it's the global initiative to ensure equitable access of COVID-19 vaccines for all countries. This organization expects the vaccine to reach at most 20% of populations across low and lower income countries by 2021. So realistically, that number will be far lower, which is unacceptable. So it's really important, I guess, that we use our power to, in countries where it is available, to try to advocate for equitable distribution of vaccines so that communities like this can be protected, because these countries will be unable to afford purchase of vaccines on their own. So in conclusion, one size does not fit all. COVID-19 is a global threat that requires a global response, but the steps to contain it should be designed locally, particularly in the crisis settings, to avoid exacerbating humanitarian suffering. And one thing that we should advocate for is equitable distribution of vaccines, because that will be the only way to really protect many of these communities. So more recommendations can be found here. This is the international rescue community's 5 key recommendations on for donors and how to combat COVID-19. And COVID-19 has shown us that exclusion kills. No one is safe until everyone is safe. These are some of my resources. And now for questions, I usually end on a slide with me and the beautiful children that I meet in these camps, but I wanted to end on our slide from the Super Bowl. Tampa has had an amazing year for sports in terms of American football for our viewers overseas that don't know it, in terms of hockey and baseball. So it's a good year to be in Tampa, even despite all of the difficulty going on with the pandemic worldwide. So thank you so much. I hope we have some time for questions.
Thank you so much, Dr. Ahson. You have really made a great summary of conditions in refugee camps and how those conditions might be related to increased transmission or risk of COVID. So thank you for taking the time to do this. There are a couple of questions that have already been posted, and I think some of them you might have already addressed. So in virtue of time, I'm going to try to summarize those questions and hopefully can make 1 or 2 questions of my own as well. So one of the questions is, are WHO recommendations different in refugee camps than they are in local communities?
So the recommendations are not different. Unfortunately, I think implementing the recommendations is where it becomes an issue. If the supplies are available or not, if testing is available or not, so a lot of places where testing is not available, we go by the isolation method. If somebody, if a patient is showing signs of COVID-19, then we isolate for 10 to 14 days or until the patient is asymptomatic. So, the recommendations are not different, but it's if they can be implemented.
Thank you. Another question is, are there any studies happening in refugee camps related to COVID and high points of transmission?
So there are. Unfortunately, we don't have a lot of good data because, like I'd mentioned, the access to testing in many of these regions is difficult. So that's why we do have some statistics that have come out. It's interesting to note, like I said, as the economies have reopened up, the second half of 2020, we're starting to see more cases climb. And as rules become more lax in terms of traveling and the world reopens up again with global travel and international flights and things like that, the cases will rise. But testing is now becoming readily available in a lot of places. Hopefully it will become more affordable and accessible to many of the organizations that do provide care in these areas. And I think then we will get some good studies in these areas. And like I'd mentioned so far, many of these communities have really been spared because of the way that they're isolated and the lack of travel and the ability to lock down. But I think, as we open up, we probably will see more cases.
Thank you. And then probably if you just mentioned this earlier, but if you could briefly just reiterate, because there are a couple of questions about accessibility. So basically the question is there access, and who covers, so who pays for that access to testing, and is there access for testing for different variants as well, and as well for treatment and for vaccines?
Sure. So I think it depends on where we're talking about, so if we're talking about resettled refugee communities versus refugee communities in, camps or urban centers, a lot of places, like I mentioned, Zaatari Refugee Camp actually has a very robust clinic that's run by UNHCR. They see about 9,000 patients a week in that clinic. I volunteered in that clinic as a part of the Syrian American Medical Society. They have they used to take volunteers on a regular basis to many of these areas. So there is healthcare provided to refugee communities in different forms. What that those clinics have accessible to them, I think varies, whether or not, certain camps have access to testing. I know in the Rohingya refugee camp, testing is very limited. Certain organizations do have testing available, but it's very, very few and limited to, very particular cases. If we're talking about resettled refugees, I think it depends on the country. In the United States, it varies from state to state and even county to county in who is covered by the county insurance. I know Hillsborough County does have free testing available through, in Tampa, Florida, has free testing available in certain locations, but you have to make an appointment and show up and all of those things. So a lot of, I think, access to the system for COVID-19 is not, I think there are similar accessibility issues for accessing the healthcare system in any resettled, population. So any immigrant population, I think, do they know where to find the information? Do they have internet access to make appointments? Can they read the language to understand how to make appointments? When they call a clinic, is there somebody who can translate to kind of explain these steps? I think that's the main issue in a lot of being able to access. So I think it does vary from county to county in the United States and worldwide. Like I said, in a lot of NGOs provide free healthcare to refugees, but a lot of these NGOs do not have funding for robust testing. So in a lot of places, they're using the high probability isolation method. In terms of treatment and all of that, I think that also differs from place to place. If you're in a country with nationalized healthcare, you're likely covered. If you're in a country where that's not an issue or, does not happen, you may not be covered. I know when I worked with Syrian American Medical Society in Jordan, if we had certain cases that had to go to hospitals, there was fundraising and things like that that happened to pay for the hospital bills for these communities. So I'm not sure if exceptions have been made for COVID-19 specifically. There wasn't a lot of information about that. A lot of the statistics that I mentioned actually come from reports from the UNHCR, from the International Rescue Commission, that these are organizations, non-governmental organizations that do their own kind of studies, and even their access right now is limited because a lot of people are not on the ground anymore because of restricted travel. So I think we will probably find out more about that in the next few months.
Thank you. That's an excellent question. Probably if we have time for another question. You mentioned a part together, and actually I collaborated in that project. There's Dr. Padilla here in the School of in the College of Arts and Sciences is the lead for the USF, and one of the things that we saw in that, particularly in the Americas, among immigrants and refugee and asylum seekers, was these feelings of not being better now as compared to earlier, and things that hinted out to issues of mental health. And we had also reported on how COVID-19, in another paper, we had reported on how COVID-19 might have impact on mental health among people in Nepal, especially considering the earthquake, the 2015 earthquakes, and
Sure.
the stress that brought up. So in that context of mental health, we know mental health it's an important concern in COVID-19. To what extent mental health services are provided in refugee camps, and to your knowledge, and I know this is a very broad question, but to your knowledge, is there any efforts on, also addressing mental health issues while addressing other aspects of COVID in camps?
Sure, that's an excellent question. So I think mental health in refugee populations is one of the most difficult to tackle areas. I've been working with refugee communities for 6 years now. I started with the Syrian refugees and then working with the Rohingya refugees, and I still am involved with organizations that continue to work with groups there. And I think mental health has been the most difficult to tackle topic. Many of these communities already have faced so much trauma and have gone through so much. So at baseline, mental health issues are very high. If you look at actually some papers, initially, in the Syrian refugee crisis, I think they were very underreported in terms of depression, anxiety, PTSD. And the numbers now are starting to report higher numbers because I think people are more comfortable talking about it because they have been settled in areas for longer periods of time and have access to a physician. I think mental health professionals that can consistently be available to groups like this has really, really been difficult because number one, there may or may not have trained enough trained professionals in these areas. I think in Jordan they have started with some programs because UNHCR does have a stable clinic there and does send health providers on a regular basis. So they have started some counseling and therapy and things like that there prior to COVID-19. I know in the Rohingya refugee camp, there really isn't anything happening yet. There were talks about trying to set up internet-based, counseling and things like that. Part of the issue is obviously language and being comfortable with the culture and talking about things like that. I remember the first time I went to the Rohingya refugee camp in October of 2017. I had, many women would come in and complain about one thing, and by the time you talked through it, it actually was a lot of psychosomatic issues, a lot of stress, a lot of PTSD, and they would break down crying in my room. And there was one particular story I remember. I cried with my patient just listening to the horrors that these communities have already experienced. And then on top of that, now they're isolated, they don't have income, and there's this fear of this pandemic and unsure of what education is going on in these communities. So unfortunately, I think mental health is always the most difficult to tackle topic in these communities. I think once there is a stable clinic that is set up, then it's something that can happen. It's just getting the correct providers there to be there on a consistent basis, because there is also talk of, you do one focus group and maybe you re-trigger and cause more harm than benefit. So it really, consistency is key in mental health issues and mental health, tackling mental health, I think. And unfortunately, I think a lot of refugee communities, we just haven't gotten there yet.
Thank you so much. I agree with you, and it's a very difficult topic. And I know that, like for Nepal and here in the US, some counselors have provided their services online or through telephones, but I understand there might be limitations in refugee camps to do something like that. But I appreciate your time, and I appreciate the time of everyone being here today. Thank you for staying a bit longer, of a couple of minutes after hour, but it's been a great conversation. And thank you, Dr. Ahson, once more. Excellent presentation. I'm sorry I couldn't go through all the questions that were posted here, not through all my questions, but I'm sure we can continue to talk at any other point. And please keep tuned for our next series conversation in the series. Have a good day.
Thank you. Bye.
Bye.